I'm Tamara, and this is TELUS Talks with Tamara Taggart. We're bringing together experts, thinkers, and leaders, busting myths, sharing stories, and staying connected when Canadians need it the most. We're having unexpected conversations for unprecedented times. Hi, everyone. Today we are talking to Dr. Michael Osterholm, who is an infectious disease epidemiologist with a few credits to his name. You said I could call you Mike. Is that okay?
Please do.
Okay. So, I mean, you have so many credits. If I go through them all, we will take up half the podcast. You are a virus detective, basically, right? Is that what you would call yourself?
Well, I would say an infectious disease detective. I've worked on a lot of different infectious agents, viruses, bacteria, parasites, prions. So I kind of cover the waterfront.
Mm-hmm. I have been reading your book, Deadliest Enemy. It's a book that you wrote in 2017. I feel chapter 13 and chapter 18, I have read probably 3 times each, especially chapter 18, Influenza, the King of Infectious Diseases. And I feel when I was reading this chapter, I was reading about today. I don't want to say you predicted this, but I think maybe people in your field, you have known this is coming, right?
Yes, we had every reason to know it was coming. It's kind of like gravity. You know it's going to happen.
So it's not a secret that we are here today. And would you say we were prepared for COVID-19?
You know, I wrote a piece back in 2005 in Foreign Affairs about preparing for the next pandemic. And I just was asked to write another piece. It's this month's cover story for Foreign Affairs, the journal. And they took the first paragraph from 2005 and inserted it as the first paragraph of this article, as well as the last paragraph of both articles. And they fit perfectly well. We were probably better prepared in 2005 for this event than we were today, in that we didn't have the global supply chains that were at risk, where people did a lot more manufacturing in their own country. Today, where we're now vulnerable to lack of drugs, critical medical products, all kinds of supplies. We have upped transportation so much so that when this spread around the world quickly, it shouldn't have been no surprise that it would show up like it did. And so when you start adding this all together, there was also finally that almost what I guess I would call complacency about, you know, we're a rich world now, generally speaking. Viruses, bacteria, parasites can't hurt us. Even those outbreaks that have occurred over the past several years of notoriety, like Ebola, well, they stayed over there. They never came to here. And we had this sense of invulnerability that was just not placed in any basis of science. And so the fact that so many people were caught by surprise was in itself a challenge, because we had a lot of work to get people to come forward. Our center put out a document on January 20th saying that this was going to be a pandemic, it was going to be bad, and that we needed to start getting ready. And yet it was still another almost 7 weeks before the WHO declared this a pandemic, before many of the governments of the world began marshaling their responses to this. And that was incredibly invaluable time that was lost in terms of being better prepared. So, yeah, I think that we got caught flat-footed. My big challenge is right now, I think we've had 3 different warnings, you might say. We had the warning before it ever showed up, and we didn't do much. We had a warning between January and March that it was going to be coming, and we only did a limited amount. And now we have a warning, and we had one in the United States, at least over the past month, that, we could knock this virus down, but we were not going to knock it out, and that we had to be prepared for a long haul. And I think that too now has been a lost opportunity to have been better prepared for what is I call the long haul of this virus, which is the months and months ahead.
On page 262, and again, written in 2017, even a moderately severe pandemic would impact just about every aspect of our lives. And then the next paragraph, hospitals and healthcare systems will suffer most acutely as long as the number of cases don't exceed the capacity of our intensive care units. This is all we have been seeing in the news. our intensive care units. We've been seeing it in Canada, in the US, Italy, Spain, China, everywhere. So I guess my point of showing, reading that out is I feel like the roadmap has been, laid out by doctors like yourself and other doctors who have tried to. Did we not learn from SARS?
In fact, if anything, we learned from SARS that this is not going to affect the world. And people came away more complacent after SARS than they did before. You got hit hard. Canada took the brunt of the 2003 SARS outbreak. And you survived it. You came out of it. You did a remarkable job of responding to it. But the United States hardly got hit at all. And so we said, why worry about a coronavirus? It's not going to be a problem. MERS, that's a problem on the Arabian Peninsula. One outbreak in Seoul, Korea. It didn't affect the world. And we didn't really expect a coronavirus. And in fact, in chapter 13, as you pointed out, the title of that chapter is SARS and MERS, a harbinger of things to come. And yet we didn't see that. We didn't have the creative imagination to see what might be coming. So I think that the real challenge we have today is helping people understand what is the inevitable with once a virus like this lands on our shores. And it's here. And so now what we have to do is figure out how we're going to respond to it. And I think that we have learned lessons with this pandemic that just have not been equally shared around the world. Look at Canada. Look at countries in Europe. Look at in Asia. They too had to deal with the horrible early rise in cases and the overrun ICUs and so forth. But then they worked hard to knock it down. And then they also put in place systems that were better prepared to ratchet up ever so slightly or maybe a little bit more to keep the cases from coming back up. So that you could, in a sense, that dance now includes not just the horrible early days of the cases, but how can we keep the case numbers at somewhat of a manageable level until hopefully we can get a vaccine, which is our long-term hope, that then can take care of it from that point on. Our country here in the United States didn't do that. We decided we had grown tired of ratcheting it down, and we were us. We don't worry about a virus. And of course, look what happened. No political will, no economic issues, nothing could overdo the impact that this virus could have. And so we're now back in a much worse place than we were just 3 months ago. And now we're in a position of having to start all over again to try to knock down the cases with what's going to have to be some extreme distancing requirements, kind of lockdown type things. In order to get the case numbers down to the point where then we can do testing and contact tracing that hopefully can keep them down. Right now, testing and contact tracing are going to have limited, if any, impact at all on this pandemic experience right now in the United States because the case numbers are just far, far too high for us to have much impact.
You talked about complacency, and do you think in a way there's almost an arrogance from some people that this is a virus that affects old people or vulnerable people? I'm young, I'm healthy, I'm going to be fine. Why can't I go out? Why should I wear a mask? How dare you tell me what to do?
Well, we have unfortunately allowed this to become a real partisan issue. I worry that far too often we've developed a policy and then we have to find the science to support it as opposed to the other way around where we find the science and then develop our policies around that good science. And that's a challenge right now. I said from the very beginning that in the end, this pandemic would not be about blue states and red states. They'd all become COVID states in the United States. They'd all be COVID colored. And I think that that's true around the world. This virus is a very humbling experience. If there's nothing else this has taught us, is we need to be very humble and acknowledge what we know and don't know. And, frankly, I think there are days that I know less now than I did 6 or 7 weeks ago. And I think that's what we have to be mindful of. Our best we can do is take this virus on and try to hold it at bay until hopefully we can get a effective vaccine. Now, I'm even, how shall I say it, smart enough to know that we may not have an effective vaccine for some time to come. Or by effectiveness, it may mean 50 or 60% of the population protected, not everyone. And then we have to figure out how to get it to everyone in a short time period. There are 8 billion people in the world right now that want this vaccine. That's not going to happen overnight. That's not going to happen in the first year. So who gets it? When do they get it? How do they get it? There are many, many questions we still have left to deal with to get back to that idea of complacency. That will not be the norm. We won't have an opportunity to.
So if there's not a vaccine for SARS, there's no vaccine for MERS. What makes people think there will be a vaccine for COVID-19?
Well, part of the issue around SARS and MERS had to deal with what you might say their market forces are, meaning that when SARS basically was eliminated from the face of the earth by exterminating all the animal reservoirs in the markets of the Guangdong province and then getting all the humans basically in isolation in hospitals, getting them into quarantine in a sense so that they didn't transmit the virus to anyone else. Then we were able to shut down SARS. MERS continues to be a problem because it's a virus that's in the 1.7 million camels in the Arabian Peninsula. And no one's going to put down 1.7 million camels. And so we still continue to see these occasional cases that flare up in humans who have contact with the camels. And then when we have a break in infection control in hospitals, we then see more spread of that virus occurring. It's exactly what happened with SARS back in 2003 before we finally shut it down. So there hasn't been a lot of financial incentive to make a vaccine for something which appears to have a limited market. But you also raised another good point. The science we do have for SARS and MERS prototype vaccines says that, we're not sure you can get long-term immunity. We're not sure just how well these vaccines will work and how that will translate to vaccines for SARS-CoV-2 is still really a question. So we have to be completely transparent and honest and say, we're into uncharted territories. People can tell you we'll have a vaccine in the next few months. We'll have a vaccine early next year. And that may be true. The question is, how will it work and how safe will it be? And those are huge questions before us right now.
Yeah, we seem to be in a time where some people don't believe in vaccines for whatever reason. And our family gets the flu shot every year. And I know people who don't believe in the flu shot because scientists are just guessing every year what that flu is. And they don't really know. And now you're putting something in your body. And I don't believe any of this, by the way, but we get the flu shot every year to protect our family and our elderly parents. And when it comes to the flu and vaccines, we become a reliant society on a quick fix, whether it's an antibiotic, whether it's a pill, whether, it's a shot for something. We assume that we'll be able to fix it quickly. Do you think the average person understands the complexity of COVID-19?
I don't think they do. I don't think they probably understand the complexity of infectious diseases in general. As a professional who's been in this business for a lot of years, again, are humbled by what I don't know and what I need to learn. But I think that what's happened is that you've hit the nail on the head when you say that people want easy answers. They want a simple solution. They want a pill. And you obviously didn't intend to walk into this area, but one of the primary themes of the book that I wrote in 2017 was about the basic day of reckoning we're going to have with antibiotic resistance.
Oh, is that chapter 17?
You're right on. There you go. Thank you.
Chapter 17 scared me almost more than anything.
Okay. Well, and I think that idea that a pill would just save us, in our great-grandparents' day, there were many individuals who, cut themselves on a piece of wire that ended up getting a bacterial infection that killed them. We saw many childhood immunization related diseases that we now think of in terms of vaccinated children that died because of those diseases. And so part of it is we take for granted what it's like to live in a pre or post antibiotic era, if we talk about drug resistance for antibiotics, or in a world where vaccines are not available. I will tell you right now, my biggest fear with COVID-19 in children is not COVID-19. That surely is going to make some kids sick, and I dare say some may die. But I worry desperately about the huge gap we have right now in kids over the last 6 months who have not been vaccinated that need to be vaccinated and have missed childhood immunizations. And I could see us the next year having more deaths due to measles in the United States and Canada than we actually have from COVID-19. So we haven't thought about those things, but yet it's the everyday activities that are there. Many, many thousands of people over the history of humankind, if not millions, died from contaminated water. When's the last time you turned on your tap and you had to ask yourself, will this be the glass of water that will kill me? Yet today in many of the low-income countries, we still have those challenges providing safe water. And so I think that a lot of people take for granted what we have or don't have and what we need to do to keep what we have. And so I think that, your question is right on the mark about complacency.
Well, and you bring up the safe water in poorer countries. We know that both in the U.S. and in Canada, we have places that don't have clean drinking water. Mm-hmm. You talked about the in one of your chapters here, I think it was influenza, the king of infectious diseases. We just talked about you talked about the simple part of washing hands, mm-hmm. and how there are even healthcare workers today that, 160 years later don't understand the simple act of washing hands. That's shocking.
Yeah. Well, if I could offer a friendly amendment to that, I think I think you've actually hit the nail on the head in a sense. They know, they just get busy and They take it for granted, and we all do. We tend to, I'm too busy to just do that, and yet it's those simple acts that end up really having a big impact on saving lives. And so it's just a reminder that at all times, hand washing is such a critical part of everyday life and should be. And skipping it just that one time could be the reason why disease A is transmitted to somebody else, and it's a real challenge.
Mm-hmm. Okay, this is. I want to talk to you about. You wrote here, as far as pandemic potential is concerned, the most dangerous places on Earth are anywhere people, birds, and swine are crowded close together in large numbers. The food markets of China and Southeast Asia, for example, or the industrial farms of the American Midwest. These viruses are deadly when they can, my understanding is from your book, that when they can cross over from human or from animals to humans, right?
Mm-hmm. That's right.
And so are we getting these viruses from eating the animals or just being in close contact with them?
Yeah, well, first of all, it's a combination of viruses and bacteria, and some rare instances, even parasites. And so what happens is there really are two different kind of categories of animals, if I could put them. One are domesticated, the farming animals, and the other ones are wild animals. And each of them have their own challenges or problems. The wild animals today are a very important source of protein, food in general for much of the world, 8 billion people all looking for food. And so what's in the jungles, what's in the rainforests, what's in many areas where wild animals are still abundant is a real challenge, because that's also where they have been isolated from humans for all of history practically. And the viruses didn't jump over into humans because there weren't humans around to have them jump into as such. Or when they did jump, they were into very small human populations. We have data now that shows that HIV was in subhuman primates long before it got into humans in the densest jungles of Africa. And when it finally jumped, it was because they were animals that were being brought in for food. They were being shot with arrows and butchered, and then the blood contact and so forth that would be had would result in the transmission. So clearly there's a whole set of those kinds of viruses, particularly viruses from wild animals to humans, that we worry about. And bats happen to be a very important reservoir or source for those viruses, and it has to do with their own immunology, meaning their immune system. They run at a different temperature, a higher temperature than than the human body. And as such, you go and look at their immune system, rabies viruses, Ebola, Lassa, Nipah, all these, kind of exotic and deadly viruses reside in the bat population, often without any serious illness. And so, but when we come in contact with them, and in many countries, these bats are again a primary food source. So again, it's that kind of contact. When you get into the domesticated animals, such as the pigs and the poultry that I mentioned, it's all about human consumption. We're not raising these for scenery. We're raising these to eat. And what happens when you get them close together, a flu virus, for example, has the capability of infecting a pig, whether they're a human or a bird virus. In other words, bird viruses don't infect humans very well, and human viruses don't infect birds very well, but the pig has universal receptor sites for both viruses. When a virus from a bird and a human commingle in the lungs of a pig, they may swap out the genetic material to make basically a third type of virus that now can still infect humans and be a brand new flu virus and cause a pandemic. It turns out that poultry are the number one bird population in the world. They have become the mainstay for protein. And so in many parts of the world, in order to feed the billions of people, the number of swine and poultry are astronomical. And they're mixing all the time with these different viruses. So it really varies by the kind of virus you're talking about. We don't think of Ebola virus in chickens. And we don't think of flu viruses necessarily in bats. So it really is about which animal population. But the bottom line is they all contribute to human disease.
Right. So are we is it our fault because we have these animals? I don't eat meat, by the way. So I'm just asking, I guess what I'm trying to ask you is it our fault because we eat these animals and we have so many of them that we're keeping them in close quarters and they're transmitting diseason to each other?
Well, we surely contribute to that, obviously, by keeping them the way we do. On the other hand, I would say to you that, poultry is the fastest conversion of energy to protein for any food source we have. So that if we're trying to feed the world with poultry-based protein, that's a very important source of food. So the challenge has been, how do we respond basically to feeding the world, and so we're not starving to death, and at the same time using animals. So it's a challenge, but it's one that we also have to understand from an infectious disease standpoint as a reality.
And how does that work in your business? When you speak to, people in the food supply business, do you know what I mean? Like, do you guys all meet? Do you pick up the phone and say, hey, like, you guys need to stop putting animals this close together?
It's a function of, I don't believe the vast majority of people that raise domesticated animals for food sources have anything but the animal's best welfare in mind. If nothing else is smart business to not have sick animals. So I think the challenge we have is that sometimes it's not due to what somebody does or doesn't do. If you have antibiotic-resistant strains of bacteria that are moving through certain animal populations, how did they get there? Well, you could have given them the antibiotics, but now we see so much antibiotic in the environment that some of these animals are getting infected from just exposure to the bacteria that are in the environment. And so that makes it tough. But today, one of the things we see is the very rapidly growing movement of getting antibiotics out of poultry production, for example, and trying to do such a good job of keeping the environment that they're born into, that they're raised in, so hygienic with such high levels of sanitation, and making sure that these birds don't have contact with outside animal species that could bring a new infectious disease to the flock, that we're now beginning to see more and more products out there where animals never had any antibiotics ever. And that's surely a good move afoot.
So before we move into next steps with COVID and what we can all do, again, we've talked a little bit about antibiotics, and you mentioned chapter 17, but you wrote your first paper, your first publication on antibiotic resistance in 1984. And Yes. And the reason I make a point of 1984 is because have things changed since you wrote that first piece? I mean,
Oh, yes,
you
absolutely.
talk
They've
about
changed.
these four things that, really need to be what we need to do so that we all of a
Hmm.
sudden aren't resistant to antibiotics, because that would be very
Right,
deadly, I'm assuming, for people.
right. Yes. Now, again, remember that we as humans don't get resistant to the antibiotics. What happens is that the bacteria where we're treating them with the antibiotic no longer kills the bacteria, or we have antiviral resistance too, where the virus no longer
Mm.
are able. So our job is to make sure that we don't make the microbes resistant to the treatment. So humans are just the place where these things grow, and our job is to try to get rid of them, or more importantly, hopefully never get infected to begin with. And so when I look back on where we were in 1984, we had much, much fewer antibiotic being used, for example, in people and in animals around the world. The world is a much smaller place. And so food supplies didn't require, in many instances, these huge, huge feedlots or, the kind of conditions that in many of the low-income countries today are marginal at best in terms of hygiene practices. So the only way to keep the animals from being sick and dying is to give them lots of antibiotics. That's just exactly the perfect way to breed resistance. So things have only gotten more complicated and complex, not less. And yet we have to continue to try to do the best we can with a program called antibiotic stewardship, using antibiotics wisely, limiting their use to only when it's necessary. And not because we're trying to save cost. It's all about we don't want to waste an antibiotic in someone who they don't need, but now exposes that antibiotic to the gut bacteria or any other bacteria in that environment where they can become resistant by just being near that antibiotic. That's what we don't want to have happen, because they can transfer that resistance to germs that can kill us.
So what happens if we don't have proper stewardship?
Well, it's not what will happen, it is what is happening. And we're moving closer and closer to what I call a post antibiotic era. We're getting closer to that time of what our great grandparents went through, or great great grandparents. It's a challenge, and there have been a number of studies done over the past several years looking at just what the health impacts would be. And one study done in England that looked at what would happen if antibiotic resistance continued unabated as it is right now. And by 2050, antibiotics and the use of them in antibiotic-resistant infections would become so incapable of killing these germs that, in fact, more people would die from antibiotic-resistant infections than cancer and heart disease combined.
What can we do as we move forward with COVID-19? What can the average person who wants to stay safe, what do you think the best steps are?
The most important thing we can do today is distance. It's the idea that if you're out and about in the public, if you're close to lots of people, you're going to be at greater risk of getting infected. Outdoor air is surely much safer to be in than indoor air in terms of the concentration of the virus. Wear a face cloth covering. We don't know how well that works, but surely it provides some protection. And just know that you're not being asked to do this forever. It may seem like forever for the next months to year, but in fact, what we're trying to do is get us to a vaccine that can be safe and effective, and that as a result of having that vaccine, we no longer have to practice these kinds of physical distancing activities.
We know that this has been devastating on economies. It's been hard for people living in poverty to isolate and to physically distance. Money is tight for many, many people. When we look at Canada and where we're at, and we look at the US and where the US is at right now, and our borders are closed for unnecessary travel, do we risk even more spread once we open those up if the US isn't more contained? Like, is it just, this is a virus that obviously can take a plane ride anywhere?
Right. I think one of the unsettling aspects of the COVID-19 pandemic for U.S. public health officials is that we are now the place in the world that people put on do not fly zone orders or closed borders to us from the standpoint they're trying to protect themselves from us. That's a very sobering notion because it's always been in modern times the other way around. It's us trying to protect ourselves here in the United States from others who might be infected. So it is fair for other countries to look at the frequency of disease that we see here in the United States, what we call the incidence, and raise the question, do we want these people, quote unquote, people at highest risk coming into our country and potentially bringing the virus? And we've done so much to keep the virus levels low. And I think it's a very, very sobering thought, but a very real one.
Dr. Osterholm, I cannot thank you enough for taking the time to speak with me today. I could talk to you for hours, obviously, and I will be continuing to read your book. You can find out more about Dr. Osterholm and his work by going to the Center for Infectious Disease Research and Policy at the University of Minnesota, or you can listen to his COVID-focused podcast by visiting the center's website. Please check out his book, Deadliest Enemy, at your favorite bookstore. It will change the way you look at viruses and how often you wash your hands and how you look at our future, really. And be sure to join us here on TELUS Talks with Tamara Taggart every week. Thank you so much, Mike. I really appreciate it.
Thank you. Have a good day.